Yes, sir. Good evening, sir. Today my topic is on ventricular septal defects. The definition, opening between the left ventricle and right ventricle caused by a defect in the wall that separates these two chambers, which is interventricular septum, is the VSD. Etiology can be genetic or environmental factors. The associations, it can be associated with the trisomy 13, 18, 21, Bacterial and charge syndromes. Anatomy, based on the location of the interventricular septal defect, it can be of four types. Type 1 is subarterial, type 2 perimembranous, type 3 inlet, type 4 is muscular. Among this, perimembranous type 3 is the most common presentation, up to 80%. Second most common is a muscular defect. Pathophysiology, during systole, there is a bypassing of blood from the right cavity via the left to right shunt and increases the pulmonary blood flow, thus increasing the left atrial volume, left ventricular end diastolic volume, and resulting in the left ventricular hypertrophy. There will be adaptive mechanisms like increasing the stroke volume, contractility, and the heart rate, and increasing the myocardial mass. Causes it leads to congestive heart failure with a late presentation of 6 to 8 weeks, recurrent respiratory tract infections, and pulmonary hypertension. Further sequelae, it can lead to a Eisenmenger syndrome. Consequence of VSD are influenced by the size of the VSD, location, and the direction of the shunt and SVR and PVR and associated anomalies. It is also influenced by shunting, pulmonary hypertension, and congestive heart failure. If the defect is small, it creates the resistance to blood flow, and it will be a restrictive type of defect. If there is no resistance, it is an unrestricted defect. These babies will present with the fatigue, sweating, rapid breathing, poor weight gain, congested breathing, and failure to thrive presentations at the later stages. They're classified based on the maximum diameter of the VSD size when comparing to that of the aortic valve annulus, like small, medium, and large, and like less than 1/3 of the aortic valve annulus diameter, 1/3 to 2/3, more than 2/3. Based on the QPQS ratio, they can be divided into small, medium, and large defect. With the QPQS ratio of less than 1.5, 1.5 to 2, and more than 2. Then coming to the defects, small defects and their changes in the ventricles. Small defects, it usually limits the shunting, and normally LV volume and RV pressures will be minimally changed, or it can be a normal, and the pulmonary vascular resistance will also be normal. In moderate defect, we can see a significant left to right shunting. Here we can see LV volume overload, LV dilated and hypertrophy, and the left atrium is also dilated. Coming to right ventricle, there will be mild to moderate elevation with the right ventricular size either normal or sometimes mildly dilated. Here the pulmonary vascular resistance. Coming to large defect, here there will be no resistance to blood flow across the ventricular septal defect. The degree of shunting here is determined by PVR to SVR ratio. The left ventricle here will be dilated, hypertrophic, and volume overload state, and the LV pressures is transmitted to RV, right ventricle. This right ventricle will also be dilated and hypertrophic, and there will be enormous increase in the pressure of ventricles. Further, the pulmonary vascular resistance is also elevated. Coming to history, we can detect this VSD in early antenatal visit itself during the ultrasound. And after birth, if it is a small defect, there will be asymptomatic presentation, and we can expect a spontaneous closure rate. If it is a moderate to large defect, this needs a medical to surgical treatment. These patients likely to develop a congestive heart failure. This will be very apparent in 2 to 6 weeks of after birth. Spontaneous closure in 80% cases, especially the muscular type of defects, we can expect. Rare in cases of inlet defect. This large defect, if untreated, it develops into a pulmonary hypertension, pulmonary vascular obstructive disease, resulting in the Eisenmenger syndrome with a presentation of cyanosis, shunt reversal with a right to left shunt, and persistent pulmonary arterial pressure increased, which is beyond the systemic pressures. So on examination, we will divide as a small, moderate, and large VSDs. Coming to small VSD, we'll have a asymptomatic presentation with a normal growth and development. And these patients will have a pansystolic murmur, upper or lower sternal area with a low intensity and high pitched levels. In moderate VSD, we can expect the growth and the development affected, and they also might have a congestive heart failure signs and symptoms with a harsh pansystolic murmur. This can be heard over the mid-sternal border radiating to the precordial area. Coming to large VSD, we can see a prominent trill with the apical impulse, hyperactive precordium with the increase in the S2 intensity. The RV will be dilated and hypertrophic, and PVR, the pulmonary vascular resistance, is also elevated. Murmurs will be minimal or absent in large VSDs since there is no resistance. Congestive heart failure presentations like poor growth and developments, excessive sweating, tachypnea, dyspnea, respiratory distress, especially during the feeding time, and recurrent pulmonary infections and hepatomegaly can also be seen. Coming to other investigations like oxygen saturation, either the patients can have a normal or a low saturation level. If we expect a pulmonary edema or recurrent infections, supplemental oxygen can improve the saturation values. But in case of Eisenmenger syndrome, the saturation level remains the same, but does not show any improvement. In chest X-ray, we can expect a cardiomegaly with increase in the pulmonary vascular markings and pulmonary edema presentations. In ECG, in large defect, we can expect a biventricular hypertrophy. In the moderate VSD, we can expect a left atrial dilatation and left ventricular hypertrophic evidences. Hematologically, coming to if it is a Eisenmenger presentation, we can see a polycythemia, coagulopathy, and thrombocytopenia. Echoes actually mandatory. This helps in the diagnosis, size, and location of the defect. It also provides information about the chamber size, thickness, pressures, and associated anomalies. Management. These patients can undergo either medical or surgical management. Medical management, these patients will be on IV diuretics and digoxin due to the heart failure. And we also need to correct the electrolyte imbalances. For the surgical corrections, these patients can undergo either transcatheter approaches or a surgical management. Indications include congestive heart failure, failure to thrive, which is refractory to the drugs, moderate to large defect with a symptomatic presentation, development of progressive aortic valve leaflet prolapse and insufficiency, which is very common in perimembranous type of defect, and the patient is asymptomatic, but the QP/QS ratio is more than 2 with the LV overload presentation, and also in the recurrent endocarditis presentation due to the VSD. Contraindications for surgery is irreversible PAH, irreversible pulmonary arterial hypertension. This increases the mortality risk. Hence, we should stabilize the pulmonary hypertension before taking the surgery. This includes like surgery. Here we can go like an open heart method with a cardiopulmonary bypass, cardioplegic circuit, and most of them include the right atrial incision. We have 5 operative approaches depending on the type of defect, like transarterial, transpulmonary, transaortic, left ventricular, right ventricular approaches. Then we also have a percutaneous device closure. This is like muscular. If it is a muscular type of defect, which is more easy in this technique with the excellent closure rates. If it is a perimembranous type of closure, it is a little bit challenging in percutaneous device closure. And this is typically not suitable in cases of Eisenmenger syndrome, AV aortic valve prolapsing with the aortic regurgitation presentations, missing rims, and supracrystal or inlet type of defects. Coming to the pre-op evaluation, we need to ideally review the underlying anatomy and physiology of the cardiac lesion, and we need to assess the pre-existing congenital anomalies also. So coming to history, we need to check for the functional status of the baby, heart failure presentation, any cyanotic spells, recurrent respiratory tract infections, GERD, seizures, reactive airways, and the drug history, what the baby is on. On examination, like general examination, airway, cardiac, and RS examination should be focused, and especially the venous access should also be noticed. Investigations, routine hematological investigations, electrolytes are mandatory because these patients will be on diuretics. And ECG, chest X-ray, echo can be done. Risk factors, what we can expect is cyanosis, pulmonary hypertension, arrhythmia. If in case of reprocedure, in case of reprocedures and the ventricular functions, we need to anticipate and explain to the parents and plan accordingly. This VST closure can be either elective or emergency procedure, and all detailed steps should be discussed and consent should be obtained, especially in the high risk group of babies. Your preparation, we need to ensure adequate NPO because hypovolemia dehydration itself will increase the viscosity of the blood and further lead to complications. Premix can be given. IE prophylaxis can be given if they fit into guidelines like past history of infective endocarditis, unrepaired cyanotic heart disease like Nielsen-Neger syndrome presentation, residual defect, then repaired with a prosthetic valves which is less than 6 months old. In these cases, we can give IE prophylaxis. Main intra concerns, we should be concerned about the air embolism, shunt reversal from right to left, pulmonary hypertension, and volume overload, LV failures. Hemodynamic goal is we need to maintain the SV, systemic vascular resistance below normal, pulmonary vascular resistance normal or bit high, and we should not lower the pulmonary vascular resistance. Normocarbia should be maintained. Peak can no peak or minimal peak is acceptable. We need to maintain sinus rhythm throughout the procedure. We can expect arrhythmias post closure, so we need to be cautious. Then adequate heart rate, and we need to avoid increase in the afterload. Induction, we can undergo either inhalational induction or IV induction. Inhalational induction, the speed of inhalation induction is unchanged here, but the hypotension and dry episodes we should be aware. Then coming to IV induction, thiopentone can cause a decrease in the SVR, and so the propofol. Ketamine increases in the SVR, so better to avoid ketamine. Etomidate can also be used since it has a minimal cardiovascular effect. Then we need maintenance can be done with isoflurane since it is cardioprotective, and analgesic with a fentanyl 30 to 50 mics per kg can be given. With the neuromuscular blockers of choice, either pancuronium or vecuronium. We need to go for the invasive monitors, CVP, invasive arterial monitoring, CVP, and the transesophageal echo is mandatory. And the anticoagulation with heparin 400 international kg should be given. Availability of the previously cross-matched blood products and prophylactic antifibrinolytics should also be arranged. Mild hypothermia during the cardiopulmonary bypass can be expected at 34 degrees Celsius. We need to maintain adequate hematocrit, at least more than 21% during bypass and 30% after 30 after cardiopulmonary bypass. Main goals is we need to avoid air bubbles, optimize the oxygen delivery and ventilatory function, avoid hypovolemia. A slight increase in preload can be given as hypovolemia is poorly tolerated because low resistance pulmonary circuit will steal the volume from the systemic circulation. This leads to systemic vasoconstriction, further leading to poor prognosis. Then coming to severe pulmonary hypertension and congestive heart failure, we need to avoid excessive myocardial depression drugs, especially from anesthetic agents. We can go for the inotropes like milrinone, loading dose of 25 to 75 mics per kg over 30 minutes can be given, followed by an infusion of 0.25 to 0.75 mics per kg per minute can be given. Further, nitric oxide can also be considered for pulmonary hypertension. Other than that, major complications. Major complications after closure of VST, we can expect a complete AV block, which might require pacing. Aortic or tricuspid valve dysfunction can be seen, especially in the perimembranous type, and residual defect can also be seen in the post-op period. malposition or embolization of the defect can be seen if it is a percutaneous device closure. Minor complications like transient arrhythmia, inguinal hematomas, and transient hemolysis can be expected. Uh, Coming to eosinophils, here we have an increase in the pulmonary vascular resistance and pulmonary hypertension is very high. So the right ventricular systolic pressure is very high when compared to left ventricular systolic pressures. So the shunt reversal, it can present as a hypoxia, cyanosis, and drop in the HVR. So we need to reduce the pulmonary vascular resistance by hyperventilating, 100% oxygen, pulmonary vasodilators can be given, like nitric oxide, milrinone, isoprenaline, dobutamine, prostaglandin, E1 analogs can be given, and we need to treat the cause. To maintain the SVR, we need to undergo vasoconstriction in these amigos. So a combination of milrinone or dobutamine with a norepinephrine infusion can also be chosen. Post-op care, we need to adequate monitoring. This VST patients can undergo either elective ventilation if we expect the hemodynamic changes, and these patients can be extubated if we have an uncomplicated VST, and if we are also doing a fast track procedure. We also should correct the electrolyte abnormalities in the post-op, and we need to maintain normothermia, and thromboelastography is also plays a very good role here. Coming to non-cardiac surgery for VST, safe conduct of anesthesia usually depends on multiple factors here, like the patient clinical condition at the time of presentation, nature of surgery, what we are going to do, and the resources available. We can safely undergo inhalational induction also. Here, opioid-based analgesia is safe, and pulmonary blood flow can be maintained here. In case of neonates, there will be a minimal neonates for with VST for a non-cardiac surgery. There will be a minimal shunting across the defect until pulmonary vascular resistance is low. So these neonates will be generally asymptomatic. Coming to older children, if it is a small defect, no major changes will be there. So anesthesia technique as usual can be done. Now coming to moderate to large VSTs or high QPQS ratio, congestive heart failure, pulmonary hypertension, these patients are very high risk groups, and we need to tailor the technique according to the individual's pathophysiology, what they have, and ideal to transfer to a specialist center. And if it is a corrected VST patient, we can treat it as a normal patient. IV prophylaxis can be given according to the guidelines. Thank you, sir.
Finished?
Yes.
Okay. So quite exhaustive, detailed presentation with how do you clinically diagnose VST?
So based on the history, like the baby is not taking adequate feeds, like poor breathing.
Will all the
I mean,
babies
I
have
don't know.
this problem? It's a very small VST. What will be the clinical finding? Supposing you get a child with a cleft lip and palate, and you auscultate, what type of murmur you will see?
Systolic
Machinery
murmurs.
movements or pansystolic movements.
Huh?
Pansystolic murmurs. If it is
Pansystolic
very
murmurs.
small,
Which location?
during
Pansystolic murmur, which area of the chest?
Midsternal area. Midsternal area.
Left sternal border.
Border.
External border,
Ready
we
into
have
the
a pansystolic murmur. And if it is a small opening and a large opening, what will be the difference in the type of murmur?
Sir, even small opening, the resistance is high, so we can expect a low intensity, high pitched pansystolic movement. In large defect, the resistance won't be that much, so we can expect either a minimal or absent movement.
So that is the first and foremost thing we have to make out, because you don't get so many cases of VST which have a very severe pulmonary hypertension and right ventricular hypertrophy, going on to the level of the reversal of shunt from left to right to left and producing cyanosis. All that is not a very rare, not a common thing to happen. So what we have to keep in mind is the simplest forms of VSD are more common. Even though among all the congenital heart diseases, VSD is the most common occurrence. It may be associated in regularly with other diseases. In most of them, is there a chance of spontaneous closure of VSD?
Yes, sir. Yes, sir. Up to 2 years of age, we can expect a spontaneous closure rates.
Right. So unless you have to monitor the child, and then if there is no progression of the symptoms, then there is a chance it may close spontaneously. So what type of workload it produces on the left ventricle? Volume workload or pressure workload?
Volume overload condition, sir,
Or
in the left ventricle.
volume. So it has to pump blood into the pulmonary circulation as well as into the systemic circulation. And that is the reason why we always measure the quantity of blood pumped into the pulmonary circulation and systemic circulation. Normally, systemic circulation volume should be more than the pulmonary circulation volume. But once it gets reversed, then only the problems all start. Okay. So these patients, what is Swiss cheese VSD? Swiss
The
cheese
muscular type of defect in the VSD usually presents in the multiple areas, resembling that of a Swiss cheese.
What is the significance of that?
It has a spontaneous closure rate of high, sir.
No, surgically it is very difficult to close because it is multiple and present in so many areas. It is surgically very not easily amenable to closure. Okay. And with regard to cardiopulmonary bypass in small children for closure of VSD with either a patch with a pericardial patch or a synthetic patch, what is the type of priming solution you should use? Is it a crystalloid prime or a blood prime?
Better to go for a blood prime, sir.
Most of the pediatric cases, you have to go for blood prime because their blood volume is small. If you use a crystalloid priming, you are likely to dilute and hematocrit will fall very drastically. Okay, so that is the reason why most of the children, when you do cardiopulmonary bypass, you use a blood priming rather than crystalloid priming like you do in mineral. That is an important difference that they may ask you, even though they will not trouble you with too much of details of cardiopulmonary bypass. All that you should have some working knowledge of how to manage this case. Okay, you have to mention about that. And otherwise, we have mentioned almost all the points in this. Where the you can see that being visible.